Thank you, Dr. Monica. Good morning, dear colleagues.
Good morning.
I would like to speak today about the synergy and functional load of short dental implants and fiber-reinforced substructures in free fibula transplants. For now 55 years, we always had the wish of the patients that they wanted to have fixed prosthesis on implants in very atrophic mandibles and maxillas, and also in reconstructed jaws. And as you see here, for many years, we use standard long implants. And what I want to talk to you today is the change from long implants to short implants. And why is it necessary to change from standard long implants to short implants is pretty easy, because if you take a fibular cross section, and we are using many revascularized fibular grafts, you see that the average supplied bone is something like 5 millimeters, and then it's not very useful to use a 15 millimeter long implant. So a 5 millimeter extra short implant is just perfect situated in the fibula. Fine. Now we are using a little thin crestal temporary abutment, so the implant will not slip into the marrow. And therefore, in 2010, we started with the question, maybe less is more, and maybe we could use a little implant like this in this transplanted bone. Today, in 2025, I would postulate the shorter the better. And certainly I will have to show you why I believe the shorter the better. If you're a sailor, you know also the change in the sailing and shipping industry and sports activity, that in earlier time it always was said the length is running. By now we know the shorter is faster. So even in sailing we say shorter is better than longer. In 2010 we started together with the Bicon company study designs with 4 by 5 millimeter short implants in the maxilla, in the mandible, and in the mandible-maxilla, with free scapular transplants or free fibula transplants, as I will show you a little later. All the prostheses fixed on these implants had all been supplied with fabricated, cut-come produced metal-free fiber-reinforced resin material, which is called Trinia. And therefore my lecture is the synergy between short implants and this new product, not so new anymore, because we are using it now 15 years, which is a metal-free fiber-reinforced resin material. And as I said already, all of these studies have been generously supported by the Bicon company. So your first question certainly will be, do they function well? And are they lasting for a long time? And I will show you a very typical patient case. A lady, 69 years old, and in November 14, she wanted to have an implant with almost none bone around here and this little bone around here. As she has a perforation and to the sinus, I decided to apply this little implant in this little bone around here. By now, today, we would use a so-called thin crystal temporary abutment, which is preventing the implant for slipping into the sinus, which sometimes could happen. In September 15, you see the situation with initial loading. Here you see the implant, here you see the big, very long crown. And certainly if you see the crown implant ratio, you will agree that's 2.5 to 1 at least. So certainly everybody thinks, good Lord, is this going to work? And surprisingly, 8 years later, loading for 8 years, you see this situation. Huge crown, little implant, but surprisingly, you see something happens inside the cavity of the sinus. There you see new bone. Very, very surprising. Once again, no bone, and there you see after 8 years. How does this happen? How is this possible? And why is this happen? So always the question is, do they function long-term? Yes, certainly they do. And why do they function so well? And we say they function so well because they are so short, and not although they are so short. And that's in the moment for you very difficult to understand, and I will try to explain to this. And all these implants have to have self-locking abutments, and I will explain you why. If you have a self-locking abutment, you have in this area a cold welding, and it's a perfect connection between the abutment and the implant.
It's clearly to see that microgap increase, and also at the enlargement we can see that there is a really large microgap.
This is an investigation by Dr. Sipprich in Frankfurt. And this means if there is movement between the abutment and the implant doesn't have to move because the motion is in this area. Contrary to this.
But if we have a look at this bicon system, this bicon interface, we can see below there is a microgap. But the interesting thing is, if we load it with 200 newtons, the microgap didn't change. So there is no micro movement inside.
So this means if you have here a tight connection and you have motion up here, then you have motion of the implant. So the implant, if you have motion, if you have loading on the crown, you have a functional load inside the bone. And this is very important and very important. So if you have a self-locking connection, you have an inflexible, rigid unit. It's actually a one-piece implant, what we are talking about. So if you have vertical displacement loading, there's no big difference between the long implant and the short implant. You have load around the implant, especially in the tip. However, if you have horizontal displacement, you see on the long implant, just in the upper third, some reaction. The rest has no reaction. Compared to this, you have around the short implant completely loading around the implant. And if you have the loading from the other side, you have it contralateral. So this means in the final, you have a roundabout turning of the implant during functional load, as Mufti has shown this with finite element analysis. And here you see the result, what is happening around this short implant after 10 years of loading. You see something happened around the load, the implant on the bone compared to the beginning status. And even more, you see this in the maxilla, like here is almost no bone. Then you augment this with resorbable material like Synthegraft, putting in the implant, and just see what 12 years later has happened to the bone due to the functional load. That's the important, and that's the red line of this lecture. The function is doing something in the bone, it's forming bone. And this already Wolf described in 1892. And he always said every change in the function of a bone is followed by certain definite changes in its internal architecture and in its external conformation. So this means bone follows function. In 2010, we started our studies, and here you see a very atrophic mandible, and all the prostheses had been performed by Paolo Perpetrini, a dental technician in Cisterna di Latina in Rome, in Italy, and also in Boston in the United States. Here you see the application of these little implants. I was afraid and very uncertain if this is going to work. And now, initial loading in June 12. That's how we started loading this implant. And you will be surprised the difference between the length of the implant and the length of the prosthesis. In this lady, it's more than 5:1. Very surprising that this is going to work. And I hope you're a little bit also surprised that 12.3 years of loading in September 24. You see, the situation is perfect, and also the clinical situation is excellent. This we published in 2021 in the Journal of Oral Maxillofacial Surgery. And I just will show you out of 18 patients with 72 implants in 8.8 years. And the survival rate had been 97.2, very, very satisfactory. But we also calculated the situation of the bone around the neck of the implant abutment connection. And we had, as I will show you a little later, why, we had subcrestal 52, epicrestal 19, and supracrestal 1 implant. And very surprising, and therefore it's so important, you see the subcrestal had bone gain. And the epicrestal, unfortunately, we had more subcrestal than epicrestal. The epicrestal lost a little bit bone. But altogether, as we had more subcrestal, our bone loss was just 0.02 millimeter. So an excellent, excellent result. And I show you a 66-year-old female patient. And after 8.5 years, you see what happened to these implants. From this situation in the bone, you see also, it's now a 74-year-old lady. She had bone gain in the crestal region. Very, very unusual. And just because due to the function. And we also measured the grayscale value, and you see the difference after 8.2 years that the situation completely changed. And this means that you had a lot of new bone formation and a lot of calcification of the bone. And our explanation why this is possible, because although the implants are splinted, you will have functional load around the implants because the structure of the prosthesis with this trinium material is flexible. How do we know that this material is flexible? Because this material is also being built in the wings of the Dreamliner 787 Boeing Dreamliner airplane. If you're on the ground, you see it's straight. And if you're up in the air, it's bent upwards, and it goes 6 meters from being on the ground to the air. So this is a very flexible material, and this means that you don't have any cantilever, and this extension here is not a cantilever anymore. It is a flexible situation, and you have here more load than here, as I will show you in a few minutes. As we had been so successful with 4 implants, we thought the stability of 3 legs on a chair is much better than on 4. So therefore, we had changed our regimen, and now we are using only 3 implants, either with bar abutments or with retentive abutments, with excellent results, as we have in this lecture here. We have 45 patients, 25 mandibles, 21 maxillas, 12.2 years survey, and with excellent survival rate of 97.1, survival rate of the prosthesis 95%. And what I show you as the statistic is the most interesting, that the longer the distal extensions are correlated with improved survival of the most distal implant. So you see, the longer the extension, even the better for the implants, because you have more flexibility. And Professor Mitchell also showed this very nicely, that the longer the extension, the better the situation is around the loading of the implant. He is from the Midwestern University. So you will ask, what's happening with the maxilla? And here you see 4 little implants in the maxilla. Very surprising that this is all going to function. 9.9 years later, you see the prosthesis in function. And also here, you see a huge difference between the implant length and the prosthetic length. Here, it's more than 6:1, and it is working. And the clinical outcome also is very nice, and the patient has a free gum, so everything tastes good in his food. So let's summarize the unique self-locking tapered implant system with a tapered connection and many, many more features, but the time wouldn't allow me to talk about everything. So therefore, I would like to show to you now our study with the free fibula transplants. And for this, we built an interdisciplinary international team. And this team was built with Professor Polidis in Leuven in Belgium, with Professor Lauer in Dresden in Germany, with Professor Petrovic in Belgrade and Serbia, and with Professor Borovan in Banska Bystrica and in Bratislava. So you see, it's certainly international, and together with our University in Vienna. So it's a European project. And by now we have already a joint publication in the European Journal of Craniomaxillofacial Surgery, and it's going to be published in a few weeks. We had 49 patients and 183 short and extra short implants, 34 prostheses, and 12.8 years follow-up of implant loading. I hope you also will be very surprised. As you know, in tumor patients, and many of them had been radiated, we do not have too good results, and therefore we are very, very happy to show you an implant survival rate of 86.2%, while the implant success rate was 78.9%. It's for tumor patient an excellent result. The implant placed in the mandible had a 13.2-year survival rate of 84.4%. This was in the mandible. And very surprising was the survival rate of the implants in an 8-year survival of 100%. Very surprising. If you will ask me, and maybe I'll get questions, a lot of questions later, my explanation is because the maxilla is loaded static, and the mandible is loaded dynamic. And therefore, the implants in the dynamic loaded mandible, it's more difficult to survive than in the static loaded maxilla. So that's a very, very interesting finding. The prosthesis survival rate at 12.8 years of the prosthesis inserted was 89, and prosthetic success rate was 81.2. And again, also in our free fibula transplants, we saw the longer the distal extensions are correlated with bone gain and adjacent distal implants. And that's, for now, for us, not surprising anymore, because the implants need to be loaded, as also here Mitchell from the Midwestern University has shown. Now let me show you our longest patient result in Vienna. It was a 70-year-old female patient. The tumor operation was 206. Here, the tumor. In our university, we prefer to close the mucosa defect by a free revascularized jejunal transplant from the small bowel. A section of the small bowel is taken out and transplanted into the mandible. And the partial resected mandible is stabilized by a long titanium plate. That's the outcome for the patient. And the tumor patient was 06. She had medical problems, and we had to wait 4 years until we transplanted the fibula into the mandible, stabilizing with these long mini plates. Here you see again the beautiful mucosa of the jejunal transplant, and here already a metamorphosis of the mucosa, and looks like already normal intraoral mucosa. In January 11, we inserted the implants, and here you see the result of the implant insertion in 11. Then we unloaded the implants in 11. And as we had a little bit difficulty with this bow of the mandible, this implant was located a little bit too much to the vestibulum. So this was not very sufficient for the patient. So therefore we kept this implant sleeping, and we had the loading on 3 implants. Beautiful outcome for the patient. And now you see the result after 10.5 years loading on 3 implants. Unfortunately, the patient passed away at age 88 in April 22, so therefore you do not see any more recent X-rays. But here are the important X-ray radiographs. You see an initial loading. You see the transplanted bone, the fibula. The cortical structure is not so perfectly oriented, and you see this little depression. 10.5 years later, you see a huge difference in the cortical structure of this transplanted fibular bone. You see, like Wolf described this in his studies in 1892, that The bundles of the collagen fibers are building a cortical structures. And you see the bundles had been building here cortical structures due to functional load. And due to functional load, the bone changed and the depression here was gone away. And this is only possible because we had this long intersection of a flexible structure due to the unloading of the middle implant. And the problem in the beginning was actually a very good situation that we had a long bridge span and we had more motion that this bone could react, and therefore bone followed the function. Here you see the same situation again in little magnification, and you see here how beautiful the cortical structures mineralize due to the function. A fantastic result. And this only had been possible because the structure could be flexible used. Let's come to the next patient out of the group from Banská Bystrica in the Slovak Republic. And this patient had a squamous, 52-year-old patient had a squamous cell carcinoma of the premaxilla and the heart palate, T2, T4, NO, and NO, M0. And here you see the after the operation, the reconstructed maxilla, also seen here on the CT. Partial removal in April 21 of the metal plates, then application of 4 extra short implants in April 21, and now implant abutments and initial loading with temporary abutments here, and you see the prosthetic work. So look how beautiful the mucosa and partially the extraoral skin looks around the abutments. It's perfectly bacterial free because you have a self-locking abutment. That's the trinier prosthesis, beautiful looking, and there the happy patient, as it couldn't be better in a situation like such a big tumor operation with reconstructed fibula transplant. And this is the latest picture. It's now 31 months, 2.6 years loading with this beautiful reconstruction. The next patient is a very dramatic case from the head and neck cancer team at the School of Dental Medicine and University of Belgrade, from Professor Petrovic and Professor Jelowak. And you see almost the complete maxilla had to be removed after this sarcoma. And here, by now, they are planning everything before the operation. They're simulating what is going to be removed and how is this going to be replaced. And here they decided to use a scapula, as this is now already planned. And here you see the final planning, and now they are checking where the position is best for the implants and how the implants should be positioned. Then there is a template, and the operation, the removal of the maxilla. Here the template is used for cutting the bone. And there also was the complete planning, and here's step by step how the planning was done. Then the planning and the positioning of the 3 implants, resuturing, and the situation in the planning. And the most important is, and this was the planning, that they had a bilateral closure of muscle and soft tissue. This is and this is now the CT after the operation with the scapula and the situation of the implants. And here you see the happy patient. And also he's even lifting his hands because the accessorial nerve was preserved. Intraoral, it's completely tied. No liquid comes from the nose to the mouth. Perfect mucosa closure and beautiful situation after the operation. As 3 had not been enough, they also applied 2 additional in the front. And this also is already published in the Helion publication journal. And now it's a 2.5-year follow-up with temporary PMMA prosthesis. And certainly a little later, it's going to be performed a trinial prosthesis. Here is the temporary, but it looks already good. Just imagine almost more than 80% of the maxilla had been removed with such a fantastic primary reconstruction and primary positioning of extra short implants. So certainly the patient is happy, and certainly we can congratulate this operating team for this excellent result. So I hope I could explain why ultra-short implants function so well, and I do not need augmentations anymore by inserting standard long implants. This is gone, this is past, we don't need this anymore. Short implants are the best. And why are the best? Because they are so short and not although they are so short. I hope you could understand the implants have to be short, have to have locking tapers, self-locking abutments. So this is a one single unit, abutment, crown, and implant unit, and therefore you have functional load, and therefore the bone answers with positive response. This is so important, and many other features of the Bicom system help to get this excellent function. So certainly by now I may say less is more without augmentations or excessive operations, just because the implants are so long. So by now I would say lengthwise, the shorter, the better. This is the implant has to be shorter. The shorter the implant, the better. But longevity-wise, the longer the implant will be in the bone, the better the bone will be around the implant, as long as you have a self-locking taper connection and you have a bacterial-free situation. If you have any questions, please don't hesitate to write me an email and ask the question, or if you would like to have a PDF copy of my lecture, certainly I'm most happy to send you my PDF copy. With this, I would like to thank you for your attention. Thank you very much.